So, 2020, what a year. Um, my name is Vicky, and I'm one of the co-founders of Joe's Valley Fest. And this was the 6th year of the festival. Obviously, we really had to pivot and change what we were doing this year. And so, since we had a virtual festival that we were going to do, I figured we'd take this opportunity to basically, hear from our community, answer questions that they have, and also be able to digest kind of the massive changes of the past, few months, and then ongoing changes that are probably likely going to happen. And for this, I'm just going to go ahead and allow everyone to introduce themselves, if they can tell us a little bit about what they do and their experiences with COVID in the field, and basically any kind of experiences that they want to share. All right, let's start with Favia. Oh, you got to unmute. I can unmute.
Yeah, I was like, okay, sorry.
Oh no, this is just part of it. We're gonna have like awkward mutes, unmutes. Yeah, it's gonna be fine.
So I'm Favia Dubik. I am a fellow here at University of New Mexico. And I like to just start off with kind of describing a little bit for people, just the training in medicine. So you go to med school, you get your medical degree, and then you go to residency that can be 3 to 7 years, depending on your field. And then you can do a fellowship afterwards. So that's where I'm at in my training. I did a pathology residency, and I am currently a hematopathology fellow, which means I specialize in diagnosing leukemias and lymphomas and any blood diseases or any disease that can go into the blood. But what we also do is run the lab. So when anyone gets diagnosed with COVID, we are the ones who gave the clinicians the actual testing, and we take it back and then we run it. And then we, tell them to relate to the patients if it's positive or negative. So we have more of a back, like not in the front, like we're like front lines because we were working 24/7 to get all these testing up, but like not like Allison, who was like seeing the patients. We were more back in the hospital, getting all the lab tests working.
Cool. I assume things are busy right now.
Yes. Very, very busy. We've actually had to divert a lot of like lab techs and energy from normal lab tests that we run to just running COVID 24/7 on multiple instruments from multiple companies, because reagents, which are the chemicals that we use to say if something's positive or negative to run the test, they're on shortage. So if you only have one COVID test from one company, you're gonna need those reagents. And if they go out, then you can't do the test anymore. So you have to have different machines that all require different chemicals. And then you have to have people trained to run these tests 24/7. It's been quite a crazy life. I never thought of pathology being like so vital, like a frontline worker, but here we are.
Yeah, absolutely. Wow, really interesting. Thank you for that. All right. Next intro, how about Stacy and Jason, please?
Hello, go ahead.
I'm Stacy DeRay. I'm a psychiatric nurse practitioner. So my involvement with COVID has been treating the mental health side of it. I work specifically at the University of Utah in their Student Counseling Center. So I've been working with mostly undergraduate and graduate students. Mostly the mental health work has been COVID and managing school studies, but I'm happy to, I think the tips that we can learn about COVID and mental health and that intersectionality with college students can apply to anyone, really. So that's my involvement.
Absolutely.
And I'm Jason DeRay. I'm an ER physician in Salt Lake Valley. Work in a handful of different ERs varying in sizes. Some of them are the big trauma centers, a couple others are the small community centers. And have just been seeing COVID patients as they walk in.
Awesome. And then I also know Allison is also an ER physician. You can go ahead and do your intro too.
Hi, I'm Allie. I am a ER resident physician at UNM Hospital where Fabia works. I'm in my second year of residency. My program is 3 years long, and then I'll likely go into the community like Jason is. So as a resident, we rotate around the hospital. So I'm oftentimes in the ICU as well. So when I'm in the ER, I will, see patients suspect COVID. Although some people come in for toe pain and have COVID, we find out they'll start coughing, and we're like, maybe we should test them for COVID. So it's a little scary because you go into a room with certain PPE on and expect foot pain, and then walk into the room and find a patient who looks short of breath. Their oxygen stats are not saturation is not very high, and then they end up having COVID. And then when I work in the ICU, that's where I end up spending a significant amount of time seeing how the disease takes its course and how tragic it can be. So it's interesting being in residency because I get to see COVID in different areas of the hospital. So that's me.
Yeah, definitely. Rotations all over. Absolutely. Okay, Lindsay.
Hey, I'm Lindsay Keegan. I'm an assistant professor at the University of Utah in the Division of Epidemiology, and I am an infectious disease epidemiologist. So my main focus is on understanding how diseases spread and how we can control them. So I've been working on COVID since late February to help guide a number of different state and the federal response to understanding how COVID is spreading in the US and in individual states, and what interventions or suite of interventions we could employ to slow that spread and get things under control. So yeah.
Oh, awesome. Yeah, excited to hear more about that. And all right, last but not least, Olga.
That's right, unmute. Okay. Hi, everybody. My name is Olga. I'm a doctor of physical therapy. And I work in outpatient mostly, both in pediatrics, and I treat patients with neuro and ortho injuries in a big hospital. But then I also do have to go and work in inpatient. And so since the pandemic started, there's definitely been more of a need to go into inpatient more often. So I have been knowingly treating patients with COVID, as well as probably unknowingly treating patients with COVID early on. And we initially went to, in the outpatient setting, we did go to almost fully telehealth to minimize the exposure, but now we are back to about 50% telehealth and 50 in-person visits. And I also do work as a PT going to people's homes for orthopedic injuries. So I can never choose one setting. I dabble in a lot of different things, but yeah, it's been interesting trying to mitigate the risk both for the patients and myself. And, I'm just always assuming that maybe I have the virus and I don't know it. So because I'm in so many different settings. So yeah, trying to manage all of that.
Yeah, well, I would be curious to kind of go from that and ask a question to you all about, I guess since I started off talking about my coping mechanisms, I guess your personal ones where especially if you're living with, thinking that you might have COVID every single day, for that, whoever has that experience, yeah, I guess just, what's been working for you and what has been, some of the more difficult aspects.
Well, I guess I could.
You want to start, Olga? Yeah,
keep
perfect.
talking with that. For me, I mean, I'm still trying to social distance and trying to mitigate risk by not, like, usually I spend a lot of time in the Eastern Sierras. I'm currently residing in Los Angeles, but California's my playground of going outdoors. I'm lucky enough to be able to do that. But especially early on, I felt like if I'm going out into a small community like Bishop or Mammoth or any of those, awesome mountain towns that we all love to go visit, I felt like even with me trying my hardest to not infect the community, I was afraid. So I tried to really stay home and socially distance until we understood more of what's going on with the virus and how it spreads. At this point, my way of trying to minimize me exposing others is definitely wearing a mask. That mask is not for me, it's for the community. A regular surgical mask is just preventing my spit droplets that are going everywhere all over my screen right now as I'm talking to you guys from landing on other people. And I just assume, you know, I'm in a demographic that I'm relatively healthy, I'm young, I could be that person that I have the virus and I don't know it. And I would feel pretty darn terrible knowing that I infected somebody else. So wearing a mask is such a simple way to not spread the virus. Washing my hands, it's amazing how many times we touch our face. I mean, I've looked at some of the studies. There was a study that counted how many times medical students touch their face. It was 23 an hour. 23 an hour, that's so many times.
Oh my God. I know you don't, and now that we're all paying attention to it, you realize how often you actually do touch your face. You're like, oh no, I don't ever touch it. Like, no, all the time.
Yeah.
So I think Lindsay, you wanted to add something.
I just want to jump in. Sorry, Olga. You're spot on about wearing a mask to protect other people. But as we've gotten new data throughout the course of the pandemic, we're actually finding that wearing a mask protects yourself as well. So we're starting to see that there's a really strong dose response for COVID. So the higher your initial dose, the worse your response is going to be. So that's why we had a lot of young, healthy doctors early on dying, getting really severely infected, both in the US and abroad. And so now we're having more and more evidence, and we have enough people now that we're actually finding that if you're wearing a mask and the other person is wearing a mask, even if they infect you, you have a 95% chance of being asymptomatic, assuming you get infected. You're much less likely to be infected, but to put that into context, it's more like 40 or 50% if nobody's wearing a mask. So it not only helps other people, but it also helps you, and it makes you much more likely to be asymptomatic, which, if that's the only thing we can hope for, asymptomatic is much better than symptomatic COVID. I have a couple of friends who've gotten COVID and they've been young and healthy, and one ended up having to get hospitalized a number of times. They wouldn't admit her, but they brought her in to the ER and gave her fluids and released her again 3 times. So, yeah.
And now you have to go to the hospital by yourself, and it's a significantly worse experience also. That's really interesting. And I do remember hearing about the viral load debate earlier on, but it's cool to hear that now there's new information where, I mean, that also just makes sense, you know, like it is a physical barrier, and yes, and so it should protect you at least from those large droplets.
Well, and if you think about it, if you have only a few virus particles that you're getting ingested with, by the time it's reproducing and building up enough to start causing damage, your immune system has gotten a head start on it. Versus if you suddenly get totally inundated, the virus is already at high enough loads in your body to start doing damage before your immune system even knows which way's up. So.
Absolutely. That is very rational and sensical. Interesting. Does anyone else have anything to add about, well, actually, definitely I want to hear, Stacy, what you would have to say about, like, I mean, what is your advice for coping mechanisms? Just going back to that real quick. And what have you seen like work and not work, and also your personal experience there?
Certainly thinking about the basics and what is in your control is probably one of the best coping mechanisms. So with the uncertainty of COVID and honestly other things that have been going on in 2020, remembering basics like making sure you're sleeping well and eating well and as climbers, fortunately, we're pretty active, and we try to get outside. I know that early on in COVID, it was harder for us to do that. And it seems now that people are able to get outside as long as they're social distancing. So I think climbers have a hand up in that regard. But yeah, I think just also recognizing, it's also easy to remember that our bodies recognize when we're stressed before our minds really realize that we're stressed. And so paying attention to any sort of changes in your emotional state, like if you're feeling irritable or angry and it's not like you, those are some signs that you're kind of feeling stressed out, or things like insomnia. So paying attention to your body essentially, and then allowing yourself time to relax. And I think as athletes and climbers, we also are really good at setting goals and really focusing on those goals. And sometimes we need to step back and take a look at the bigger picture. So maybe it's not about sending a route or a boulder problem, it's about just appreciating climbing. So those basic coping mechanisms can help, especially when we're so detached from others and we're feeling more alone. It's remembering, what can I do? What's in my own control? What can I do for myself? So
Yeah,
that's
that totally makes
basic
sense.
stuff. Yeah,
Definitely. The control thing, because it mostly feels like the rest of the world is absolutely out of our control. So just doing anything that we can to actually retain it. And I think, including wearing the appropriate PPE and also just being educated in this and feeling like we have the right information is a huge part of it for me. Okay, and then we also have some cool stuff going on in the chat, but we'll get back to that later. But Allison, it sounds like you had something to say.
Yeah, I was just going to say, where Fabi and I do residency and fellowship at UNM, they took it super seriously very early on. And we actually weren't allowed to leave the state for, I think it was almost 5 months, maybe 4 or 5 months. And now if we are going to leave the state or go anywhere in the state, we have to check covidactnow.org. And we have to make sure that there are less than 8 per 100,000 cases in the area. So we are like barely allowed to travel at all at UNM.
That was COVID Act Now?
I think it's, Bobby actually sent me the link. COVID
I'll
Act
type
Now.
it in the thing.
Yeah.
Thanks. Awesome. That sounds like a very good website to know about, especially if you're thinking about moving locations. I think, this kind of ties into some of our questions that we have previously received via social media. So physical distancing of 6 feet is not well understood when it comes to an activity that involves movement, i.e. walking, running, or cycling. What is the risk, especially with new data in the past few months? And some have suggested that contact, quote unquote, with an infected person requires more than a moment in their presence. Is there any science around the length of exposure? Which I'm sure Lindsay has something to add to.
Yeah, so what we're finding is that indoors is definitely worse for contact than outdoors. But getting back to the 6 feet, the reason the 6 feet isn't super well understood is because it's still kind of up in the air of whether or not COVID is aerosolized or if it just spreads through droplets. Droplets basically are the spit that comes out of your mouth, the say it, don't spray it, as you were a kid. Aerosolized is where it's like actually floating in the air. And so measles is a good example of something that's aerosolized. It can hang in the air for up to 3 hours. With influenza, there's still a lot of debate about whether or not it's aerosolized or whether or not it's really small droplets, and the droplets take a long time to get to the ground. But with the droplet idea, 6 feet is how long it takes the droplet of that size for gravity to bring it to the ground. Basically, if you fire a gun, eventually it's going to hit the ground. It's the same idea with firing particles out of your mouth. So 6 feet is a good distance for most of the droplets to make it to the ground. When you're indoors and you have to worry about the aerosolized component, if it's hanging in the air, it's going to be a much bigger problem if you don't have a constant stream of fresh air. Whereas if you're outside, the air is moving, you have airflow, you're not just breathing in the same air that other people are breathing in. When you're indoors, we've had a number of studies that have mapped out where people were sitting at a restaurant, and based on the air conditioner, like the airflow patterns, you can see who got infected and who didn't. And so indoors, it becomes a little bit more complicated. So outdoors, if you're walking, if you're running, yeah, it probably is a little bit further, because when you spit out, you're breathing heavier. So you're going to spit it out further, and it's going to have more velocity coming out of your mouth before it hits the ground. But my personal opinion, and I don't have data to back this up, is because the risk is so much lower outside because the air is moving and flowing, I still stick with the 6-foot guideline. There have been some studies early on to show how far, and for bicycles, it could be as far as like 20 feet or something like that. Is the air that the person in front of me 20 feet, is it the same air that's going to hit me in the face? Unknown. So that's sort of why this is up in the air. Indoors, it's a lot more straightforward, right? You don't have wind, you don't have, other phenomena that are impacting where things are going. You're just all breathing in the same air. So indoors, it's especially important to wear your mask and social distance to prevent that. So sorry, it's not a clear answer. It's sort of the thing with COVID is everything's a little hand wavy at this point because it's so new and we're still trying to figure out everything in real time.
Absolutely. Yeah, but really good advice. And I'm sure everyone has had different experiences passing people on the street, and the social contract has not yet been formed. And so we're all still just trying to figure it out. Does anyone have anything to add about that? Okay, I will move on. And okay, so I have barely any experience with masks, but somebody asked, like climbing and masks. I've been basically just haven't been doing too much rock climbing lately. But I'm curious about physical activity and masks. The person specifically asked, any ultra lightweight masks out there that'll help me send that nar on the reg? Just to be specific. So has anyone found a good mask that works, especially for climbing? And otherwise, I did go climbing once and I just wore a surgical mask. I did find I was hyperventilating inside of it, so I didn't find it super comfortable. All right, Favia's put on a pretty nice looking mask.
I have a Maskini, which I love. It has the PM 2.5 filter that goes in it, and it's awesome. It's made out of a bikini. It's basically like one boob of a bikini, and it's super cute, and I like it.
That sounds awesome. Maskini, nice.
Yeah. I wear it when I run.
Lindsay?
Oh yeah, one sec, I'll go get it.
Yes, take it. And Favia, I've seen you in this mask a lot.
Yes. So this is the Sportiva mask, and it actually has filters that you can put in and change. And it doesn't, I have bad sinuses, and so any pressure on here gives me bad headaches. And so this one doesn't, and it allows me to breathe. So I'm a fan of it. So
yeah, right.
For bouldering, it's not that big of a deal because I do 3 moves and I'm done. But now that I started doing a little bit more lead climbing, I see why it's important, and this doesn't seem to bother me too much. And then I also just wear the surgical masks as well.
Mm-hmm.
So this is my Maskini. It has adorable fruit on it, and it has this little filter pouch, so I can get these replaceable PM 2.5 filters that are maybe $1 each. So yeah, it's awesome. Super lightweight without the filter.
At the climbing gym that sometimes Bobby and I go to, we are required to wear masks there. And any cloth mask, I cannot breathe at all. I feel like it's super heavy. And my face is pretty small. And so the surgical masks we get at the hospital actually are they feel pretty cheap, I guess, but they're very, very thin. And they're tested, so I prefer that just because it's pretty just light, and when I sweat all in it, I don't have to I just end up throwing it away, which is, I know, wasteful, but I feel like there's COVID over everything. So I kind of like throwing my mask away anyway. Like when I leave the hospital, I take it off and put a new one on because we're required to wear them outside anyway. But you know, like if it's droplet based, it's going to be all over your mask anyway. So like touching it in the car when you leave, you're just putting it on your hands. So I think it's nice to just take it off and throw it away when you leave a place with people.
Sounds like that's overall an agreed better way to do things also, since the virus, I don't know if there's any new information about that, but I know it still can live for a few days. And so I remember some of our poor healthcare workers having to clean PPE between runs. So, okay. Anyone else have anything to add about awesome masks? That was a hilarious question, but also super useful, 'cause very, very difficult to find masks. All right.
I would say the one thing that you don't want to do is wear the like gaiters or the buff. So I don't know if those listening have seen the study that came out of Duke University, but they noticed they went through a whole bunch of masks. I don't know, Lindsay, is that what you linked in the chat? Yeah. Okay.
Yeah,
so
that's
Lindsay,
what I linked.
yeah, Lindsay linked it in the chat, but basically that a buff just disperses even more droplets. It's like if there's a big drop coming, it gets broken up into smaller droplets. So it's actually more that you're exhaling. So don't do the buffs.
Good tip. No buffs. Unless, I guess, if you have a filter in the buff, would that be better?
I don't know if you can make
They make now buffs with they have filter pockets.
Oh, that's news to me. That's cool.
Yeah, you know,
Yeah, I
all
don't know.
this new ingenuity from. Awesome.
I think one
All
thing
right.
with the masks, the CDC recommends 2 or more layers. So I think part of the problem with the buff is just one layer. You know, if you blow through it, clearly air gets through. So maybe if you double or triple it up, you know, more than one layer of fabric would help, or kind of bend the buff over a couple times. But I think most people just wear one layer, pull it up. It's light, you can breathe through it, you can blow whatever you want through it, which I think is the problem there.
That makes sense. So, okay, if you only have a buff, at least fold it, at least double it.
At least
Yep.
double, maybe just quadruple that up and throw that on there.
Well, yeah, it sounds like actually just literally the more layers, the better.
Or just don't go inside and stay 6 feet away from other people, and then you don't have to worry about it. You could take, I don't normally endorse walking off the trail, but if you don't have any way to cover your face and you're in a place that is, either in a high risk group for being asymptomatic, so you're rather young, or you're in a place that is, you know, you're coming from a high risk location and going to, or high COVID location and going to a low COVID location or low resource location, just stay 6 feet away from people, walk off the trail, give them a good berth, turn around when they pass by.
Oh yeah,
And-
just like the actual covering. Go ahead, yep.
And I would say the other thing, like sometimes there just isn't space. Like I've met people in a stairwell and they don't have a mask. At least turn away then. Like that's an easy thing to do. Just completely, it's a little antisocial, but wave high and then completely turn your body and face away. So then you're not getting droplets on them or vice versa.
Totally. Yeah. So basically, at least turn away if you can't do anything else. But at least we have the outdoors. I'll take it. Okay. So continuing, another question that we've had is about travel, and the person writes, I've seen a lot of larger organizations saying things like adventure locally, as well as states having varying degrees of recommended maximum travel distances. When it comes to community spread, how far is too far when it comes to getting outside? And I'm probably going to start with Lindsay again, because this feels
Sorry,
right up
this
your
is what
alley.
I've been thinking about. Like these types of questions are basically what I've been doing for states for the last like 6 months. So if anybody else wants to take it, like go for it. But basically the idea that we're thinking about is there isn't a single rule of thumb. The problem is that when people mix, that's how COVID spreads. That's why we had lockdowns, that's why we have social distancing, and that's why we're recommending you to stay local. And so if I've been working primarily with the state of Utah and the University of Utah, So I'm going to use Utah as the example. So right now, as of this morning, I got a notification that Utah County has a case rate of 850 per 100,000 individuals, whereas the rest of the state is more like under 200 per 100,000. So if you're somebody from Utah County and you are thinking of traveling to, say, Moab, and you're in the demographic of 18 to 30, who's much more likely to be asymptomatic, well, I would recommend against that, in part because Moab has 3 ICU beds. So if you, a young, healthy person, goes to Moab, you go into a gas station, you go to a restaurant, you go to a grocery store, and you have asymptomatic COVID, and you spread it to people in Moab, they're not going to be able to handle a big outbreak like Utah County, which has a major hospital system. They're going to overflow their hospital really fast and then end up having to move patients up to Salt Lake in Utah County. And so the idea that you're trying to think about is, am I going from a hot spot to low COVID location with also low hospital resources? And so that's what you want to avoid. So if you're in Salt Lake County and you want to go climbing in American Fork, well, you're putting yourself at much more risk, but you're not at risk of bringing COVID into that community. So you need to decide, is it worth it for me to potentially get COVID? But you're not putting that community at risk, versus if you're going to Moab, you're putting that community at risk. So that's sort of the concerns that we have.
Definitely makes sense. So I'd be curious if anyone has anything to add, and also what you're, oh, yep, Bobby, go ahead.
So as we mentioned earlier, that site actnow.org, that one is a great one to use because it actually tells like hospital, like ICU rates and, the positivity, and it goes county by county, state by state. So you can see, everything that Lindsay just said is on this nice website. So you can better calculate your rates if you're putting people at risk or if you're at risk by using that. That's
awesome. And it sounds like you basically implement that into your decisions. Same with you, Allison. Yeah.
So I actually get alerts because I'm dying to go to Waco. And, it's high. And so I have alerts for all my favorite climbing destinations of when it gets below a certain level. And well, actually it just says it's a little heartbreaking. It says the level has changed. And I open my email. I'm like, ooh, maybe it's low.
Oh, no.
And so I was like, it has increased. And I'm like, no. But yeah, it's based on a 7-day average. So it's like updated every day. And so I check it nearly every day to see if these averages are changing. And then it's just good. You can see the trends in certain communities. And I use it here for myself because if there's a big spike here in Albuquerque, it's like, well, maybe I was going out to sit outside on patios, but now it's not if I see it spiking, then I say, well, now's not the time to be even leaving the house or going to the climbing gyms. So I use it for my own personal safety as well.
I'm going to put a plug for the Utah Department of Health. They have a great website that does this too. And if you scroll all the way down to the bottom of the first page, it tells you also by neighborhood, which is so cool. So for the bigger counties with fewer people, it's by county, but for Salt Lake and Utah Valley, you can actually zoom in and see the avenues and Rose Park and see the different rates within each individual neighborhood, which is really cool for, as Fabio was just saying, decision making, because it is really important to know if you should sit on a patio.
Absolutely. No, those awesome tips. And I guess I would be curious if anyone has any more things to add about that, and also if they can, talk about personal experiences at the hospitals and, with caseload and what's going on with you right now. Do you have a lot of COVID cases? Does it feel like things are more handled? And I think, you're getting the hang of things, if that's, an appropriate way to talk about it. Yeah,
I guess I'll start with the Salt Lake Community Hospitals, not University of Utah. I think Lindsay can speak on that. But the other hospitals throughout the valley, I would say 3 weeks ago, we had very little COVID. In the biggest hospital in the valley, we have an area of the ER that only sees respiratory patients. So if you have a cough, fever, diarrhea, any symptom of COVID, you get placed in this COVID unit basically. And 3 weeks ago, you go have an 8-hour shift and see 3 people. It was beautiful. You just surf the web, watch TV, is great. And certainly over the last week to 2 weeks, it's been ramping up. And I think that just represents what's happening in Utah. You know, if you go to that COVID Act Now website, we are a red state. You know, like Lindsay was saying, the rates are quite high. We've had, you know, higher positive rates over the last couple of weeks than ever. So I think we're just seeing that uptick. So certainly in Utah, things are ramping up a little bit. And it's a wide range of people who tested positive and look great and you send them home. But definitely you're still getting a good handful of people who are pretty sick and need oxygen, need to be in the hospital. And it's sad to see, I suppose.
Likewise in Albuquerque, we're also having a rise of COVID in the last couple, I guess like 2 weeks. We had like our biggest spike, I think in July, and then it was going down nicely and now it's starting to go back up again, which like our chair of our emergency department was kind of predicting might happen. I think like with how it feels going to the hospital, when this all started, I would have like, I used to get really excited to go to the ER, you know, like what am I going to learn? What am I going to see? And then when COVID started, it was kind of like a lot of nervous anxiety, like, am I going to get this? Like, am I safe? Is there going to be a mask that fits me at the hospital? UNM's pretty poor, and my mask size was out for like 2 months. So I was wearing the same N95 for 2 months straight. And so someone gave me a small 1860 N95, and I like have like it hanging in my room, like just in case it happens again, you know, like it's a little bit anxiety provoking, but I think now I go to the hospital and like, it's just normal. Like I'm just used to it. It's not that it's gotten like better, it's just I'm used to it. And then in New Mexico in general, in the nation, we had such a bad outbreak for the Native American population, which has gotten better. But they're a super vulnerable population with their living situation, access to news, access to hygiene, and just different masks and knowledge about what's going on in the state as well. So I'm extra careful because of the population that I see every day, because I don't want to pass it to anyone in the Native community, because just giving it to one person will spread it amongst the whole entire tribe, really.
What about in the physical therapy field, Olga? I'm curious, and you know, if you, especially with COVID having happened for a few months, I remember hearing about people having kind of like long-term issues, and I imagine that might be people that you see.
Yeah, so in the hospital, initially we weren't treating COVID patients when this first happened, because everyone was pretty low level. And then as patients are recovering, they really do need physical therapy because, I mean, I've seen a very wide range of how people recover. You know, I saw a 30-year-old who could barely sit up at the edge of the bed for 30 seconds because he was so weak. And then I saw like a 70-something-year-old lovely grandma who was just a little bit wobbly as she was walking around the room. So at this point, they do need physical therapy to get up and get moving so that they can get home safely. For me, like as a PT, I am all up in your business to help you do that. So I am definitely getting more used to it. The hospital does go through PPE short. I don't think we were quite as bad as what Allison had to go through, but they stopped all elective surgeries for a while because surgeons had to reuse the same masks between surgeries. And we definitely have to reuse some of our masks. But I don't know, there's still some anxiety for me there. It's like, did I clean off my PPE? Did I take it off correctly? Did I sanitize my hands perfectly between each one? Did I touch my face and I didn't realize it? But I don't know, you can't have that get the best of you. So I just do the best I can, try to follow the protocols. I definitely find myself on some days paying attention like I'm getting more used to it. So I almost feel like I'm paying attention less and have to remind myself, it's like, okay, this is the new normal, but it can't be so normal that you're skipping steps. Yeah, in terms of outpatient PT, like I said, we're still, if a patient really needs to come in so that because I need to physically do something with them, like get rid of a trigger point, or I think that this is really going to benefit them in the long term, then it's my decision to have them come in. Otherwise, if I can treat them virtually, and I think they're going to benefit from things like strengthening or different, changing their posture, things that they could do on their own, I try to keep it more virtual. Otherwise, I'm wearing just a surgical mask and a face shield to protect myself, and washing my hands before and after, and cleaning everything like a mad woman. But yeah, everything
We've
smells
all
very
learned how to
clean.
clean very better,
Yes,
much better.
exactly.
Yes.
Yeah.
Cleaning, absolutely.
So the televisits have been an interesting change for physical therapy, because we're so used to getting information. I get so much information just from watching how someone moves as they're walking over to my booth even. So the virtual care has been interesting with the angles and everything, but it's been working overall.
And it of course going to take time to get used to it. And I think, I don't know, I didn't think we were still going to be where we are now. And so it's still kind of this, getting used to it again and realizing it's going to be a long run.
Yeah.
Does anyone have anything to add about the other experiences? All right. And I have a question I'm definitely curious about, and since we're talking about we're in it for the long run, there's been a lot of talk about herd immunity lately, and I had a question about, is it actually possible with COVID? And person says, I guess they don't understand how we get to herd immunity, what exactly it means in practical day-to-day life terms, and also basically they've heard of reinfection. So what's the news on that?
So I think this is me. So it's a complicated question, and there's a couple of different pieces. So let's bear with me as I walk through it. So the base idea of herd immunity is just that the disease needs to contact susceptible people in order to spread. So if I'm in a room with people who are all immune to COVID, no matter how infectious I am, I can't spread it to anybody because they're all immune to it because they've either been vaccinated or they've already gotten it. So that's the idea of herd immunity, is that you limit every individual's ability to spread so much that the disease stops spreading. And so there's a really simple way to calculate that for what we call a permanently immunizing infection, which is something like measles, where you can absolutely never get it twice. And so for a disease like that, it's just 1 minus 1 over the reproductive number. So for COVID, that's about 2.5. So 1 minus 1 over 2.5, which is what, 60% of the population needs to have gotten COVID for it to stop spreading. Now that's assuming that every single person is spreading to exactly 2.5 people, which we know already not to be true. What we're finding in household studies is that either everyone in your household gets infected or no one in your household gets infected. There's no like 1 or 2 people out of 5 people get COVID. You either everyone gets sick or no one gets sick. And so it could be like demographics about a household. So they could be higher densities, or it could be disease related. And so if it's disease related, if some people are just better at spreading than others, which is sort of what we think to be true, then it actually can be less than 60%. So that's some really good news. The bad news is that it has to be a permanently immunizing infection, which means that you can't, or you need to have a long enough period before you can get COVID again, that you have some time where everybody is immune. So if it were like 10 years, which is sort of what Zika is, you can get Zika once every 10 years, we think. Maybe, we don't know. It's been, 4 years? So we'll see. But that is long enough that you can have it die out. But for COVID, the really bad news is we're starting to see reinfections, we're doing neutralizing antibody studies in the lab and starting to see that people are losing immunity in 4 to 6 months. So if it really is the case, this is like 3 data points that I'm talking about. So it's not enough to generalize to the whole population, but if you remember, COVID's only been in the US for 6 months. COVID's only been in the world for 10 months, 9 months at this point. So, you know, we don't know, but assuming that immunity only lasts for 6 months, then herd immunity is out the window. So there's a lot of big questions, heterogeneity. So that idea that some people spread to more, are more infectious than others, that helps bring that number down, but loss of immunity maybe throws it out the window. So it's still too early to tell, but I'm leaning towards we have to wait for a vaccine.
I mean, definitely sounds like it. We'll have to wait for more data points, but yeah, really interesting, and thank you for the explanation of herd immunity. All right. And I think there was some good questions in the chat, and I saw that one of them I know you wanted to answer in person, so I wanted to make sure to give it time. Kyle asked, do you all have any findings that support the idea? Oh, cute. We just answered that one. Funny that. Nice work. All right. And I think everything else. Oh, yeah, Fabio.
You did
please.
ask one question about the COVID tests.
Cool.
So the accuracy of the COVID test definitely depends on the lab that is running it and what test that they chose, and if it's a legit lab. Because right now there's a lot of people who, you know, somehow get their hands on tests and aren't. There's still in the lab, you have to do validation. You have to make sure that the test is, you know, sensitive and accurate, and in this case, like rapid. But there are people out there who are skipping steps, and so like it's not clear if their tests are actually good. So you need to go to a legitimate lab to make sure that your tests are actually giving you the correct information. And so generally the PCR tests are very accurate, but it's not all 99%. Like some have been like 80%, up to like 99, and it depends on where the test is coming from. So we've been testing, like particularly in China, they've tested a lot of different places, like rectum. So I actually so like for 3 months in residency, my only job was answering laboratory COVID questions. And so like someone read this paper and they're like, oh, are you guys doing rectum tests now? And I'm like, no, we're not. Because each place that you test, you have to validate. And so that's just a lot of work. And then that's different testing kits. And so like for people like Jason and Allie who are out there, we don't want them to like be on the field and stressed out and have the rectum kit, the nasal kit, the mouth kit, the ear kit. And then like if we take the ear kit and put it on the rectum kit test machine, it's going to be, you know, wrong results. So like for our lab, Tricor, we in the beginning of COVID were doing like 75% of tests for the whole state. Now I think it's down more to like 50%, but we kept it very simple. We were only allowing like nasal pharyngeal tests so that everyone had the same type of test and they didn't have to worry about, you know, that issue. And then another thing that comes into play for the accuracy, particularly for the antibody tests, is like, when are you taking those antibody tests? Because if you just get exposed and you ask for antibody test, it's not going to come up. There have been some studies that they have supposedly come up at 4 days, but generally you need to wait 7 to 10 days to get that antibody test for it to, you know, really reflect your status. So the testing part is really complicated. And the part of it was, can other coronaviruses give a false positive? So that's all part of the validation, because that was one of the big concerns. And we actually have tests for, and it was very confusing for the clinicians. Like we had a coronavirus test that tested like for everything but COVID-19. And then we had a COVID-19 test that only found COVID-19. And so there are exact tests, I mean, to the best of our abilities, that they don't get the other coronaviruses and they get the COVID-19.
And I know I had a friend recently, to follow up on that testing question, do a spit test, I think. So now we have those in the US. That's new, right? And if anyone could kind of speak to that, and maybe even if Avi, if you want to continue speaking the different types of testing. So I think mostly are still going up your nose, but now with the spit test, and that's more rapid also in some cases.
So I'm unfamiliar with the spit test, but I can imagine how it works because we in the lab get other spit tests, like for other, diseases. And there are a lot of now rapid tests, we call them point of care tests, that have very good accuracy. So in the beginning, the point of care tests weren't very good, but now we've gotten so that the point of care tests are a lot better and a lot more reliable. But I haven't heard, I don't think our lab is doing that yet.
We just started doing at ARUP at the University of Utah, we just started doing saliva testing PCR. So it has the same sensitivity and specificity as nasopharyngeal, but it apparently has a 2% failure rate, where in 2% of cases, it gums up the machine and it doesn't give any answer. You just have to resample. So they're in the process of trying to work that out, because obviously if you want to do any sort of serial surveillance where you're testing the same population multiple times, like they don't really want to get something stuck up their nose multiple times. So asking people to spit into a cup is a lot easier. But yeah, I think it's still really new. I think we just started rolling it out last month.
Yeah, ARUP is like our biggest competitor. And ARUP actually is where we send our send-out tests to. So we're a reference laboratory, which means many other smaller laboratories send their stuff to us. But then when we don't have a test, we actually refer to ARUP. So that would kind of make sense that they just got it, that we're slightly behind, but we're coming for you.
Yeah, so they do it for PCR, but they're trying to work out some kinks. So maybe when they work out the kinks, you'll just steal it and run. So. Fabia, I have a question for you, if you don't mind. So
yeah.
We here in Utah, we've been doing this big HERO study where we have been doing serology, where we test blood for antibodies, and we found that in about 20% of people who tested positive for PCR previously in the epidemic, they like self-reported, I had a positive COVID PCR test. They're not testing positive for antibodies. And so the hypothesis is that the level for antibodies is actually set based on hospitalized patients, and you may be missing the more mild cases. So this is not to test for active infections for the other people on the call. This is to test for, have you ever gotten COVID? But it's interesting. Have you heard anything or seen anything with that?
No, but sort of. So in the beginning, there were a lot of tests done like on autopsies, and the people who died from COVID, because the pathologists, we also do autopsies. Like we do strange things. And so like the extreme effects, like when you're dying from COVID, the viral load, everything's like really high. And so that wasn't really, the information we were getting from autopsies didn't translate all that great to people who weren't just dying from COVID. So seeing that, I can imagine if they're taking that from the hospital source and people who aren't as sick to be hospitalized, it wouldn't work out that great. But now I've only seen it from like comparing people from autopsies to people in the hospital, and there was a difference. But no, sorry.
Very interesting. All right. Anyone have anything else to add there? And I have, okay, and Sarah has a question. So if the answer is seasonal vaccine, then is the outlook that we will be doing a seasonal vaccine and permanent social distancing / masks?
I mean, I think it's too early to tell any of this, right? Like the data that I'm citing for this not being permanently immunizing is 3 people, which is not what we're going to base any policy off of. And if you look back to the 1918 flu pandemic, eventually we did get back to normal. There wasn't mask wearing forever. So hopefully we'll get back to normal. It may take longer than people want. I know my new personal stance is that during flu season, when I take the bus to work, I'm wearing my mask because there's always people coughing and sneezing on the bus, and I don't really like getting sick at all. And a mask is such a small inconvenience to not ever have to get sick with the flu or colds. So, but hopefully Hopefully not. We don't know yet. It's still way too early to tell.
I was in Korea. Oh, sorry. Go ahead.
I was just gonna say, I'd like to add that I know people find masks annoying, but there are many positives that I've actually, I'm kind of in a camp where I prefer to wear a mask, like even after COVID, like I might still be wearing a mask. Like it keeps me warm. Like I'm cold all the time. I no longer have to worry about food in my teeth. I don't have to worry about lipstick. Like I only have to put on makeup on half my face. So I'm really kind of enjoying this. It's not a popular opinion, but I'd like to throw that out there that like mask wearing protects you from infections, but there's also like other social embarrassing things that it protects you from. Oh yeah, and boogers in your nose. Like you don't have to worry about that. So
No, it's so true. And what I was going to say was, yeah, I was in Korea last year, and I mean, the masks are common. Just when you have a cold, people wear a mask to protect other people. It's just a very normal thing. And we're just a little behind, I think. All right. And then I have one final question. It's 6, so is everyone okay to stay for just a little bit and answer this one? Awesome. I would love to hear about just personal experiences. Again, any stories of surprising COVID cases, or how basically certain COVID cases have surprised you. And if there's nothing like that, also just yeah, what you've been surprised with in the changes of your life, what's been like most difficult to deal with, or anything like that. All right. I'm going to start with
Me.
you. Yes.
I guess I can just give a surprising case in the ER. I think Allison was saying, sometimes people come in with toe pain or some unrelated complaint. You end up getting an x-ray or something, you look at their lungs and you're like, oh yeah, this person has COVID for sure. I was working with a colleague today and we were just talking about kind of weird cases. And the first COVID patient he saw presented with a headache, neck pain, fever, no cough, no respiratory symptoms at all. So the physician I was working with thought it was meningitis, did a spinal tap, and it happened to be meningitis. It just turned out that he had no respiratory symptoms from a COVID infection. I think his CSF grew out COVID. So it was a COVID meningitis, and the patient did really poorly. But it's just crazy, the people you go in and you see things, you don't have all of the protective equipment on, and then you think it's something totally different, and just how many people actually have COVID that ends up coming back positive. 3 days down the road, you get a phone call, like, what did you wear protective equipment wise in room 10 the other day? And you're like, a mask, that's it. And then it's kind of, you're watching for symptoms, and I think it just illustrates that it is actually pretty prevalent. That's all.
Yeah, it just seems you just can't stop hearing those kind of cases where, and like what you're finding in autopsy also, Flavia. But yeah, Stacy, do you have anything? Since I was like, you're already unmuted, I figured I'll call you out.
Maybe I'll just take this time to make a plug. I don't know if when you post this recording online, if you're going to add resources, but I have several apps that I think are great for mindfulness in particular, as that can be another thing that's in your control when it comes to the uncertainty of all this. How long is it going to go on? Will I be able to keep my job or maintain connections with friends? So using these apps help. There's also a couple of websites for online therapy that I'll share, both for anybody. And then there's some websites specifically for people of color, which can help, I think, considering our cultural climate. So that's what I'll share now. It's just that plug of resources that we'll add to this Joe's Valley Fest.
Awesome. And yeah, we will have this recording, and I'm also definitely happy to include all those resources, the website that Flavia gave us, and then I'll get that list from you. That'd be awesome. All right. Olga, you're to my right, so.
I would say for me, the biggest surprise was just how wide of a range of symptoms there are in terms of the kind of patients that I've seen. So like when I see that I have the way we're doing it is we designate one physical therapist, that's the COVID PT for the day to minimize risk. So you're treating all of the COVID patients for PT in the hospital for that day. And yeah, I have no idea what they're going to look like. Am I even going to be able to treat them? Maybe they're too low function and they can't even catch their breath while they're sitting, or are they going to be pretty normal and just a little bit off balance? Yeah, so you kind of just go with the flow with that. The other thing that's been, I don't know if it's necessarily surprising, but just in terms of my own management and like adjusting to all of these changes, it's been surprisingly easy for me to do the, social distancing while walking down the street, or just keeping that in mind, which has been, I'm a very extroverted person, so I like to be around people, but I think having seen patients makes it easier to be like, yeah, I'm going to keep my distance because I was just at the hospital and I don't want you to be infected just in case, especially if we're not both wearing masks for whatever reason, right? Just like Lindsay was saying, apparently I'm protecting myself too, but I want to protect them.
Absolutely. No, I used to leave, used to be like keys, wallet, phone as you leave the house. And now it's like keys, wallet, phone, mask. Do not forget that. Different masks for different types of activities, it sounds like. I need a better physical activity mask, but now I know the kinds. All right, Lindsay.
I don't treat patients. I don't like gross things. So I work with the data that that healthcare workers send me. So thank you guys so much for being willing to treat patients and to give me all of this really useful data. So I don't have any interesting patient stories, so I will use the time to give my epidemiologist plug, which is to remind everyone that the COVID pandemic is not an inevitability. It's not something about the epidemiology of the disease. It's an interaction between human behavior and the disease. So you can help limit the spread by changing your behaviors to wear masks, social distance, wash your hands, just be more mindful of your own behaviors, and we can help slow this thing down. So just trying to remember this is not inevitable and we can stop this.
And it's not forever.
It is definitely not forever. I mean, even if you look at the 1918 flu, where they had way fewer resources, eventually life got back to normal.
Absolutely. All right, Fabia.
So I kind of already mentioned the big surprising thing was that pathologists are like pandemic workers. Like I thought like ED, yeah, I thought like I'm not going into ED because I don't want to be like stressfully managing something like this. And then look at this. Here we are supplying all these tests and trying to make sure they're accurate. And recently, like we think of COVID tests, like us putting on COVID tests is our main thing, but actually the COVID patients have a lot of clots, and that's like a side effect of the disease that has been killing some people. And like there's various lab tests for clots. So now like every COVID person is getting these clot tests. And so it's like various parts of the lab. And those tests aren't very easy to run. They're very manual. And that part of the lab, like there's no machine really to run a lot of these tests. Like a person has to like tap it, mix it, pipette. And so they're running this 24/7 now, which is something they weren't doing before. And so it's just kind of interesting how COVID has impacted other non-COVID parts of the lab. Now it makes me very worried for like running a lab in the future. Like, oh my goodness, I thought I'd be sleeping at night.
I thought this was predictable work.
Exactly. I was like, I leave the unpredictable stuff to like Jason and Allie, not me.
Surprise. Yeah. Oh man. That is a really, really interesting twist to the plot. Absolutely. And yeah, I was a public health major at college and undergrad. And so it's definitely, I never thought really honestly that public health would be so in the limelight. And it's definitely been a very interesting year. So, all right, Allison.
So I think Jason pretty much took care of like COVID presents in all sorts of ways. Like people come in with heart attacks that they maybe also have COVID. Maybe that's why they had a heart attack. So it can really be anything. And so like in a place like the emergency department, we always kind of have to have our ears up, and we have areas where we separate COVID, likely COVID, or just everything else. And a lot of times we're like, that patient should be there. Oh my goodness, like I'm not wearing the right thing. And just kind of be flexible with it. But I'll just put a plug in, since we kind of talked about that, just for if people who are in the front lines, for anyone listening, it's really good to check in with them, because a lot of times we have gone into these fields to help, and COVID can be pretty defeating, especially in the ICU. The providers that work there full time, it's very sad. They do every single thing that they possibly can think of and do, and there's no fixing some patient outcomes. And so it's just a very sad situation. And for people who have gone into a field to, provide care and make people better, and with this new thing that we can't really predict and can't really understand completely is taking over the ICUs, it's very overwhelming. I feel lucky I don't have to work in the ICU at all times. So just reach out to people on the front lines, friends, family. Everyone pretty much is having issues right now. So, but yeah, we're doing our best.
That was the first time I did that the whole time. I'm actually impressed. Anyway, thank you. Well, I was trying to thank you for your work, but then obviously I was on mute. So, what are you going to do? Yeah, thank you all so much for your time. I don't know if anyone has anything last minute to add, but since it's already 6:10, I will, stop this, although I could talk to you all forever with all this interesting information. But yeah, thank you again so much, and I will be getting this posted probably in the next 24 hours, and I'll wait to get any other resources that you guys have too. Feel free to email me, and I will add them to the Excel events page. All right. Thank you all so much. Good night.
Thank you, guys.